Please welcome to the stage, Mariel Concepcion, MD, owner and CEO, Big Trees MD.
So with that, let's get started with our afternoon sessions. We are going to be talking about pushing boundaries, unlocking potential, and growing fast, but growing smart. And with that, our first speaker is Dr. Vance Lassey. You're going to hear a lot from him because he's current president of the Direct Primary Care Alliance.
Please welcome to the stage, Vance Lassey, MD, owner, Holton Direct Care, president, Direct Primary Care Alliance.
Jeff, you were right. These lights are bright. And I made that joke about this being a rave this morning, that you used. And I don't know where Zach is. I can't see out there, but I got my little bag of tricks, the little swag, and there was no ecstasy in there at all for being at a rave that we're at. I'm going to do this talk without any hallucinations or anything. I'm really happy to be here, and thank you very much to the folks at Hint to put this really nice, get this place for us and everything to use. So pushing boundaries in DPC is what I'm talking about. So whenever Zach asked me to talk, I was intrigued by the, thank you very much, Mariel. So I was intrigued by the concept of the request for a talk about controversies in DPC, because if there's anybody who likes to talk about controversies and isn't scared of conflict, it's probably me. And that's not all good, probably, but what's nice in this case, in this scenario today, is that Delicia already came up here, and I was a witness to this. I watched all of you guys raise your hand and say, yeah, I'm not going to be all judgmental about anybody's opinions, and everybody can say whatever they want, and that's all good, because now I can say whatever I want, and it doesn't matter how much it pisses you off. You already raised your hand. I saw you do it. So we're going to talk a little bit about some of these boundaries, and see if I can get the clicker to work. Oh, I'm like, see, there we go. I'm looking at the wrong screen. So pushing boundaries is kind of what I'm known for talking about. I've talked about it a lot. There's a lot of controversy in DPC. I'm going to talk about mainly boundaries just because of time constraints. But this is a talk where I want you guys to kind of get uncomfortable and be comfortable with discomfort. And like I said, we don't have to agree on all this stuff, but we certainly all need to know where the movement is and where we are, and respect each other in that movement. So the three things I want you guys to learn today is the importance of the value proposition in our movement, and that watered down care is not direct primary care. And if you're not pushing things, maybe some ways you can learn how you could. So we're going to go into DPC controversy via what I call the DPC Alliance Hall of Presidents. So I'm the current president of the Direct Primary Care Alliance. We were formed by just a ragtag group of docs 5 years ago who, up until then, any sort of conglomeration of DPC doctors helping each other was done just kind of underground in little groups of docs in various regional areas, and those have still blossomed and are doing well. But we decided to go together and make a nationwide organization that supports physicians who want to get out of the system, who need to get unplugged and take care of patients and do it right. So that's what we did. And when we did, we unanimously elected this guy here, Ryan Neuhoffel, as our president. So he was our George Washington. He was the one that unanimously we said, you're the guy who can unite us and help us to grow. This was 5 years ago. And Ryan kind of took it to his head and got all this George Washington stuff. And I'm known as a really, really good Photoshop guy. So I do 20-second Photoshop, which isn't bad Photoshop. It's just that I'm so good at it, I can do it in 20 seconds. And so he asked me to make him a Photoshop of the George Washington. So there it is. And that's on the Hall of Presidents. So now Ryan was here 4 years ago, and I wanted to quote him. This is a quote I transcribed it directly from the video. DPC docs are opinionated, idealistic, and maybe naive. We want to remain true to those core principles and values that made DPC what it is. When we do start getting outside influences or things that might try to change the way that we practice, we need to make sure we stay true to those principles. Saying some of those things, and this is what I wanted to highlight, is uncomfortable. And then to paraphrase him, he talked about how we disagree on a lot of things. We need to make sure that when we are growing DPC, we're not doing it at all costs. I cannot say it better myself. Ryan was awesome. So what I'm saying today is we're not going to agree on everything, but that's okay. We can find some common ground. So there's an easy place I think we can all agree on if you have just a lick of common sense, and that is that in the free market, value is everything. It really doesn't matter what you're selling. If the price is wrong or the service quality is bad, no one's going to pay you money for it, particularly now whenever inflation's costing everybody $550 a month more just to live. We have to have a value. There has to be something of worth for people to want to send their money our way to take care of them. So with that said, we go into the Hall of Presidents, Volume 2. I don't know, I'm blinded by the light, wrapped up like a deuce. So now there she is, Julie's here. So Julie is our John Adams. I talked to Julie last week and I was like, hey, are you cool with me photoshopping you into John Adams? And it'll be a really high quality job. And she said, I'm more of a Betsy Ross than a John Adams. I'm like, really? I don't know. But if you say so. So here we go. This is our Betsy Ross, is Julie. And Julie was here in front of the Hint Summit group in 2017. So it'll be 5 years ago. Oh, wait, before I talk about what you said, I got to talk about Thomas Jefferson, which is me, since I'm the third one. It's only fair that I do a 20-second Photoshop job on myself. And so what I did was I gave myself Thomas Jefferson hair, which, you know, I don't know. Honestly, I think it looks pretty cool. So I may have to grow it out and get a wig or something. So, okay, what she was talking about was this graph, which we love to talk about. And anybody in the audience who's not a doctor, you're probably some form of administrator. So you hate this graph. And that's okay. You need to understand what the problem is. And in 2017, Julie basically said the yellow is the problem. And of course, she was right. And so this is what she was talking about whenever she said the following. All the business people in the room, I challenge you. You better bring value to the table if you want to set foot in my clinic. So we're back to the thing we can agree on, right? We can agree the value is important. And then she said, if you march into my space wanting to be a part of this, you better understand what it is. And when she said it, she was talking about authentic, I'm going to paraphrase her as saying authentic primary care. She had just got done telling a story about how she spent the entire evening with a patient who was dying of cancer at the bedside at their house. That's authentic medicine. That's the stuff that authentic direct primary care doctors do. And it is not amenable to the system that we came from. You don't have that kind of time to form those kind of relationships, which are integral to this value proposition that I'm talking about. So this is the place where I think we can agree. So here we go into how the DPC value proposition works. So when it's right, this is my little catchphrase, everybody wins. So in the lower right, you see it, that's like a screen cap off my website. I say everybody wins. It's on my hat. I had hair for a while. I have really curly hair, and I was trying to compete with Zach for the summit, but then I realized I'm completely bald and it looks stupid. So my 13-year-old daughter shaved it off last night. So anyways, and I don't have the male model thing that Zach's got going on. I try, but I can't compete, man. And my accent's lame too. So who can win? Number one is patients, obviously. The physician in the practice can win, and the employees of the practice. And then what I call the adjacent entities, so your vendors, free market specialists, imaging centers, all the people who can benefit from the free market. But even the middlemen were applicable or necessary. So this is where I'm going to first start pissing people off. Save space. It's not necessary always to have middlemen. I'm not saying that we can't do it right. I'm not saying it's not even possible and there aren't people out there doing it. But at the same time, for all of you who haven't done this yet, there are those of us who've built practice. I have 2 clinics, 3,000 square feet each, built in less than 6 years with no debt, 5 clinical practitioners, 0 middlemen, no employees, no employers, no people getting us practice. We did it ourselves in the middle of nowhere. So if we can do it, it is clearly possible that it can be done. Now, can it be done with all the middlemen? Probably, but it needs to be transparent and done right. That's all I'm going to say about that for now. So everybody can win if we do it right. So what is the value proposition? It's this. It's that we're different. And those of you still inside the system, and I've heard it talked about this morning, that difference has to stay there. We cannot change back to the way we used to do things. And I would argue that a lot of the way we did things, not necessarily by choice, but the way it worked out, was we watered it down. We want us to see 20 or 30 people a day? Great, but I can't do these complicated workups. I can't do a lot of these procedures because I got to move. I got people in 3 rooms need to be seen. So refer. All of that increases the price and decreases the quality and the accessibility, and it's a hassle for patients and so much more. So I would assert that we cannot be watering down our care no matter how we decide to implement DPC. Whether you do what I do and you move out into the middle of nowhere and literally build a building by yourself in the middle of a cow pasture and start seeing patients there, you can't water it down. So it doesn't matter how you do it. So let's look at a little bit of before and after DPC. And I know this is annoying to have someone read slides to you, and I hate to do that, but I wanted this to be in the slides because I want you guys to be able to take this home, look at it, and in case you want to use it for your websites or whatever. Let's just do a little compare and contrast, just 6 things. So let's talk about time with patients. On the inside, it's less than 8 minutes. You guys know that a veterinarian spends more time with his or her patients than we do, right? On the inside, that's true. So if you want to give patients better care than, say, I don't know, a dog, then you might want to look into direct primary care. So 30 to 60-minute appointments are the norm. In my office, everybody's 60-minute appointments. On the inside, physician doesn't have the time and refers patients to specialists. I would also assert that because of that, they start losing their skills, and then they stop doing it, even if they want to, just because they're out of practice. And on our side, on the outside, we have the time to research and handle more complicated cases. On the inside, patients are referred out for even minor procedures that we can learn or relearn and practice. So the other three are access. So this is the stuff that we heard from this morning. Texts, emails, after-hours calls. We can do all that stuff because we have a limited panel size. Time allows for it. The practice model pays for it. And we don't have so many people that it's oppressive and interferes with our lifestyle. That's absolutely impossible on the inside. Also, their panel size is huge. I'd love to hear about some panel sizes. I know mine was over 2,000. Whenever I was on the inside, I'm sure most of you would have a similar story. Obviously, in DPCs, the panel sizes are smaller because there's no free lunch. Something's got to give, and that's what it is. No personal and relationship, no relationship and continuity issues that are done very well on the inside. We get to do that. So this is what I would encourage all physicians doing this or wanting to do this to do. If you're not already different, get that way and then stay that way. So now I'm talking about professional value. So when I say, what do you offer, doctor? I'm not talking about, oh, we have, whatever, low prices on x-rays and medicines here or something. I mean, professional value. What is it that you yourself offer that is a value add that people are willing to pay for? Number one is accessibility. Same-day appointments, text messaging. Do you get to them quickly? Email, same thing. Can they call you after hours? In a little bit, I'm going to tell you a story about a phone call I got last night. First call at night I've had in over a month. Service is the scope of your practice. So what all do you do? Do you do procedures? Can you learn to do more? What is your expertise? Are there things that you always refer, but you're like, you know what? I'm a doctor. I went to med school. I can learn how to take care of complicated cases of hyperthyroidism or whatever. So learn it. So what do you offer that and make it so that people have a good reason to give you their money? And what about time? Do you take plenty of time and do you demonstrate a pattern of building continuity relationships? So I'm going to talk a little bit about what kind of boundaries can you push to create value. The first one is get uncomfortable, just like this talk. It's not easy to be told that you should do something different, and everyone's like, oh, you think you're better than me because you do that. No, it's not that. That's not what I'm saying. What I am saying is that, yes, there's this thing you've heard us all say. If you've seen one DPC, you've seen one DPC. We all do things a little differently, and that's a good thing. On the other hand, if I say I sell a car and it's got a body and windows and an engine and tires and it gets a certain miles per gallon or something, and I sell that for X number of dollars, and somebody else sells, let's say, I don't know, a car with no engine in it and 3 wheels. Okay, that's a car. But people probably aren't going to pay for it, at least not nearly as much as they would pay me for the car that runs, and so on. The more you take off your car, the more you've affected your value proposition, and the more you've hurt yourself. And we'll get back to the people who do complain about why they're failing in DPC when they're not pushing these boundaries. So obviously procedures is one. Learn them, relearn them, get some practice, do what you got to do. The Direct Primary Care Alliance, we built it for this purpose. We have lots of doctors that are eager to help each other out and form a relationship, a tight-knit group of doctors who you can bounce things off of and learn things. And there's lots of resources there. And by the way, if you haven't heard about the DPC Summit, it's the DPCA puts it on with the AAFP. It's next month. We have 3 days, 3 tracks, 101, 201, 301 content. There's something for everybody. You can learn a lot of this stuff easily. So take the time to learn that stuff. Here's one that's controversial, getting hospital privileges. So many doctors have gotten out of the practice of doing inpatient care, even though they were trained that way. That's a concern. It's one thing you can learn and you can probably do. It's challenging some places more than others. Be available, get in touch with people, reply to texts and emails and stuff like that. And then obviously emotionally invest. That's just huge. Okay. Examples of doing this. So these are procedures. There's nothing on this list that I don't know at least one DPC doctor who's doing most of them. I mean, there's maybe a couple things some people don't do, but in general, there's a lot of this being done in the direct primary care world. But in the inside, a lot of this isn't being done because of time constraints and all the other things that get in the way of a full spectrum practice. So I'm not going to read it to you, but learn some procedures and do them in your office and reap the rewards of having a good value proposition. Services. All right, so this is where you do specialized counseling. So maybe you've got raging ADHD, so you're good at talking to kids about that and helping them figure out how to cope with that. Maybe you went keto and lost 90 pounds, and then all of your patients want to know how to do it, and now they're all losing lots of weight too. Cash in on it. That's a service you can add. Counseling, whatever, all kinds of testing, cardiometabolic stuff. I don't have to read it to you. These are great ideas of places you can add services and add skills. You know what? This was the old version of the slides. Dang, there was I sent him a new copy of the slides this morning because after this one here where I talked about, see the seventh one down or whatever it is, the orthopedics and procedures. So last night I went to Kansas City because I had to get on an airplane like at 5 this morning, and it's a couple hours drive, and I was really late getting there to my in-laws where I crashed because as I was leaving the clinic, I got a phone call from a 7-year-old girl who broke her arm, and it's both bone fracture, and I really wish I had the other version of the slides to show you guys because it would make a lot of you who aren't doctors probably want to go lose your lunch, and you would lose weight in a not healthy way. And it's a gross picture, but it's pretty awesome. I got her mom and dad, they got a hold of me. We got her into the office. We got her set. We got her reduced. Got her splinted up, straight as an arrow, looking great. She did awesome. Hematoma block, And that's an example of something not a lot of people in family medicine are doing anymore. What do you guys think we saved that family on that little girl's both bone fracture of her forearm last night? So our little hospital in our town doesn't have doctors in the ER anymore. They staff it only with mid-levels, and the mid-levels don't really have a lot of experience in this kind of stuff. So I already know what would have happened had I not answered that phone call and been there for them. They would have gone there. They would have got a $2,000 or $3,000 bill for even being there after the x-rays and stuff. The NP or the PA would have sent her on to Topeka, probably by ambulance, which I've seen them do for tiny things. And then she would have the ambulance bill, then all the charges for propofol or Diprovan or whatever they do for, sedating them, ketamine and stuff. I mean, last night I saved that family, I don't know, throw out a number. Easy 10, right? 20,000? It's like an auction. No one even dares stop because it could be 100. Nobody would be surprised anymore. Yeah, you saved them 10 infinity dollars. Yep. Okay, so I wish I had that picture because it was just last night, and it would have been so perfect to see you guys, so you guys could see and go, yeah, that's just last night. This one story, and there's so many like that, which is another thing on this whole we need data to prove all of this. How many people here are Chris Farley fans? Give me some. We got some Tommy Boy fans in the house. Does DPC work? I don't know. You guys don't have any EMRs that really fully bring in all the data. I can't tell by your 99215s. I don't know if you're really cutting down costs in the ER. I really don't know if you have decreased hospitalizations. You guys just aren't giving us the information. You're not clicking boxes all day like all these other people are. So I don't know. I guess it doesn't work because you can't prove that it works. I can get a good look at a T-bone by shoving my head up a bull's butt. You know what? I'd rather take the butcher's word for it, right? I can't prove how much money I saved that family last night, but we all know I did. So you just have to take our word for it. We are making massive, massive financial improvements on our patients' behalf. And I'd argue, and a lot of times, most of the time, the care is infinitely better too. So, all right, these are boundaries I want you guys to work on pushing. Text, email, cell phone after hours urgencies. This is where I want to talk about that. I don't know what my time left is, but I have a few minutes to discuss this. One of the doctors out in the DPC universe hit us up online, one of the message boards or something, asking about they're just not growing like they want, and maybe I should make a deal with some broker who's going to want 20%, but they'll bring patients from some employer, and then I don't have to. I don't know, I'm just sitting around, and I've only seen 2 or 3 a day. I'm not making any money. I'm having to moonlight all the time, and poor me, I'm just so bored, right? No, you're doing it wrong. So I've said this before. When she texted that, this person this time, or put it out there on the interwebs, I was like, if you're bored, you're doing it wrong. And so ever since then, Josh Umber, some of you guys know him, he runs Atlas. he's just taken that and he's really active on social media and I'm not. And he posts that all the time. And so I'm gonna end with that. You're not gonna grow if you're not active. And I don't mean just having patience, because word of mouth will get you there if you take good care of people, but not overnight. It takes time to organically grow. So get out there, shake hands, kiss babies, go talk to library groups or the quilting guild or something. And it does not take long. There are people that are in this room who packed a panel of 500 or 600 patients in less than a year. It just takes work. I think that's as long as I have time to talk about controversies. Some people get mad when I say this. DPC is not something that's supposed to be easy. Do you maybe only see 6 or 8 patients a day sometimes? Well, yeah, and that's great. But you're spending an hour on them, and you're digging into their chart, and you're doing your research, and you're not just glossing over this. It's still hard work, and you're running. Most of us, I mean, not all of us, if you're employed or whatever, but we're running a business, and that's not easy. And my dad, one time after I did this, he was visiting, and it was one of those nights where I worked until like midnight, just doing paperwork and whatever. And I hadn't come home yet, and he was eating dinner with my family, and I wasn't there or something. And he was like, I thought this DPC thing was like easy, and you'd be home more, and whatever. He's old, and they say grumpy things. And I'm getting old, and I'm starting to say grumpy things too, so it's okay. It's no big deal. The point is, and what I told him was, Dad, I'm a doctor. I signed up for this. Yes, it's way better than before. Many of you have heard me talk before, know that I used to miss all my kids' games. Now I coach the team. Those stories abound in the DPC world, and it's a good thing. But at the end of the day, you're still a doctor. You've got people who are relying on you. You've got people that you can make a massive difference in their life. And not to mention, you can save them money, bring a better quality and access and all that kind of stuff. But you can't do it without working. So I hate to step on your toes and just tell you, yeah, after slaving away inside the system for all this time, now you have to go, that whole thing about I'd rather hustle 24/7 than slave 9 to 5. Yeah, that's true. And you have to do that. You have to go work 80 hours so that you don't have to work 40. But it's worth it. And at what wonderful way to do it in helping others, right? So that's what it's all about. It's all about patience. I think that's all I have. And yep, that's it. If we have more time, more than happy to entertain any questions. I don't know where we are on time. It doesn't say on my screen here. I was so worried I wasn't going to get to all of it, so I talked really fast. So, you don't have to clap. Does anybody know, do we have time for a few questions? Who has a question before someone yells at me and says we're out of time? Great question. So I didn't work with any employers. I did it all myself. We do now have a couple of small employers that pay us their patients' membership fees as a benefit to them. And there's really no difference in giving them the money, letting them pay it, except for that they get the tax benefit of it. But seriously, out of thousands of patients, maybe we have 10 of them that are employed, then their employers pay it. I did have a leg up in that I was already practicing in this town for 9 years inside the system for a hospital. So I already had a big panel of a couple thousand people, and just like most people who transition like that, 10% of them followed me, so I had a couple of hundred who were ready to go when I launched my practice. The other thing is, honestly, the question about how do you grow in a rural area, I don't think it matters. I honestly, my success has, if nothing else, has told me, I don't think it matters that you're in a small town versus a big town, because I've got a second clinic that's 30 miles away in another small town, and we're growing there. And I honestly believe that word of mouth does everything. And here's the thing, and I think I'm talking, I know I'm preaching to the choir here, but on the inside, you guys know what the norm is. The norm is it takes 3 weeks to get an appointment or longer. When you get there, you got to wait in the waiting room for an hour or two. You're lucky to get 6 or 7 minutes of the doctor's time. The doctor's so busy trying to get their RVUs. They're sitting there looking at the computer and clicking away on boxes, and they don't look at you. They don't make eye contact with you and do all these things. We all can tell horror stories. I've got some good ones, but that's what it's like. That's what they're used to, even in the small towns, even in the rural areas. And then they come to a clinic like mine where they get a same-day clinic. They can see me, they can call me at 9, and I can get them in at 1 or something. Give them an hour of my time if they need it. If they don't need it, they get less, but whatever they need. I text them a few days later, hey, how you feeling? You feeling better? Those kinds of things. All of that like the kid who's broke her arm last night, her mom and dad paid for her membership until she graduates from college, and she's 7 with one broken arm, right? So when you provide that different, I mean, we're talking so different level of care, people can't help but tell their friends. And so I really think whether it's urban or rural or in between, the word of mouth does the job to grow your clinic. I've never spent money on advertising or that kind of stuff. It's just I really take good care of my patients. They know I care about them. They know I want what's best for them. I'm always their advocate and all that kind of stuff. And the level of care is night and day compared to any time in the system, and it just grows. Is everyone going to have that experience? I can't say that, maybe not, but it certainly worked for me, and I've heard stories of lots of other physicians it's worked for them too. So that's how I did it, but it was nothing special. The question is, could you do it without a pre-existing panel? I think that might be a part of that question. I think so. I still think you could. I mean, when I hired my first partner, he didn't have a practice in my town in Holton. He came from a town nearby and didn't bring a ton of patients with him, and he grew and filled in about a year. So I don't think that you have to have that. It probably helps to already have a name and have people know you and so on. But I think it can be done anywhere. I think it really can. Now, I will say this: if you're a clinic in a rural, underserved area, word gets around because it's underserved and people need doctors. Maybe you get into some of the bigger or urban areas where there's clinics and doctors everywhere. Then you're not this sort of proverbial big fish in a small pond. Now you're just one of many tiny fish in a huge pond, and it may be harder at first to grow. But I do believe that once you start and you start getting a handful of patients that are telling their friends, the organic growth tends to be pretty common story. So great question. And until someone yells at me and tells me to get off the stage, I'm going to keep entertaining questions. Are we done? We got out of time? Okay. Thanks, guys. I enjoyed it.